Good morning, everyone, and welcome to this year's annual Frank E.Lucente Resident and Alumni Research Day. Thank you, Dr. Lucente, for being here today with us, for your unwavering support of this program, your unwavering support of faculty and residents individually continues to be inspirational to all of us. So thank you for being here. I have the pleasure of introducing our keynote speaker, Dr. Kathleen Yaremchuk, who, as Dr. Bencianoff and Dr. Lucente just alluded to, is also someone who has been an inspirational leader within the field of otolaryngology, a friend and mentor to many, and again, someone who is considered to be, by myself included and many others in our field, an exceptional role model of what it means to be successful in academic medicine. So Dr. Yaremchuk got her MD at the University of Michigan and did her otolaryngology at the University of Chicago, and then has spent the bulk of her career at Henry Ford Health. She is currently the chair Emeritus of Otolaryngology-Head and NeckSurgery, the divisions of Audiology and Oral Maxillofacial Surgery at Henry Ford Health, and served as the chair for 13 years. Dr. Yaremchuk's numerous leadership roles within otolaryngology and within various subspecialties are too numerous to name right here, but I'll just focus on some of the highlights. She was the president of the American Academy of Otolaryngology-Head and NeckSurgery from 2022 to 2023. She's had other important roles in our important organizations, including serving as a senior examiner for the American Board of Otolaryngology-Head and NeckSurgery, an associate editor for the Laryngoscope. And she's also received numerous awards for her service and her research accomplishments, including the prestigious Jerome C. Goldstein Public Service Award from the American Academy of Otolaryngology-Head and NeckSurgery Foundation. She's been the president of the in Otolaryngology section, as well as a vice president for the middle section of the Triological Society. So Dr. Yaremchuk's clinical focus and what she's known for nationally, internationally is in sleep medicine and otolaryngology, and she's board certified in that. She's held several leadership roles in the International Surgical Sleep Society, and so this is where she's really kind of made an impact and actually was really instrumental in developing the Sleep Medicine Center at Henry Ford Health. She's published extensively in this role and has had leadership experiences since leaving the chair role at Henry Ford Health, including being the chair of the Board of Governors and the chair of the Quality and Safety Board there. I just want to say on a personal note that Dr. Yaremchuk really goes out of her way to extend herself to leaders throughout our field. She's been a wonderful friend and colleague to me. I appreciate her friendship and her mentorship, and because of her wealth of experience, I think she's, in this chapter of her career, has also taken on coaching and mentoring other leaders, not just in otolaryngology, who are really looking to help understand kind of what it is required to be in these very important and challenging leadership positions in academic medicine. So I'm going to bring her up now, and her first talk today will be on, I think, again, this theme of leadership. The title is Where Have We Been and Where Are We Going? Thank you, Dr. Yaremchuk.
Thank you so much. I mean, it really is an honor to be here today, so I want to thank you all for having me. You know, the title of the talk, Where Have We Been and Where Are We Going? It's probably more to just let you know that there's less than we know than we think we know, which is probably true for a lot of things. Conflict of interest, nothing that I'm going to be talking about today. I'm going to talk about the past, the present, and the future, because I think if you don't know where you've been, it's hard to tell where you're going in the future. So we'll go through that. So I always think there's something you should be able to talk about at a cocktail party someplace in your life after hearing a talk. We all know about CPAP. And I always thought that CPAP was invented in Australia by Colin Sullivan. But in fact, it was Elliot Phillipson, and it was in Toronto, which is just down. Okay, sorry. Is this better? Okay. So it was invented by Elliot Phillipson, actually in Toronto, 1970, and it was used on bulldogs and pugs. And you know, bulldogs, pugs, they have the short face and all of that kind of thing. It was actually a paint compressor with reversed airflow that was used to develop this, this device. So Sullivan heard about this in Australia, came to Canada, visited, improved it. I think, and I don't want to say he stole the idea, but he certainly maximized it. He developed a patent on it, sold it to Baxter. Baxter became ResMed. ResMed was actually, it moved from Australia to California, and that's the story of CPAP. The first machine weighed 14 pounds. Is anybody here on CPAP? Okay. It's now 4.9 pounds. So just so you know, and I've always seen it. It goes through TSA, it goes through all that kind of thing. The first surgical treatment for sleep apnea came from Stanford, and I'm going to say that was published and that we talked about, and it was about tracheostomy, actually here, Pickwickian syndrome. And then the study series was 72 trachs, and I love, if I could publish back then and we could describe patients as having short, fat necks, how would that be? I can only imagine now if we submitted it to Laryngoscope or the White Journal, it would get sent back in no time. Average AHI 65, cardiac arrhythmias, desaturation below 40%, and asystoles. Once again, I can only imagine what the sleep lab would do today with those kinds of patients. And then Shiro Fujita, who was at Henry Ford and a colleague, wrote about UPPP. And this was the first article in the American literature about UPPP. The thing that's interesting about that and why he even developed it was there was an article in a Japanese journal, and it was about UPPP for snoring. And since he was Japanese and he got the journal, he read it, and he goes, well, maybe if it works for snoring and all of these patients snore, this will work for patients with sleep apnea. And this is one of those articles. I think, once again, it's a classic. There's an ENT, Dr. Conway is a pulmonologist, Dr. Zork was a psychiatrist, and Tom Roth was a PhD, and Tom Roth is still doing research and still active at Henry Ford Hospital. So 12 patients, 11 men, once again, short, thick necks. They talked about snoring, they talked about difficulties with nasal obstruction, and what they found out of this series of 12 was that 8 patients got better, 2 were about the same, and 2 actually got worse. And you know, we talked about research. Dr. Lucente talked about that. And at that time, Dr. Fujita said there's a variable response to UPPP. It's important to determine what subgroup of the sleep apnea patients would benefit from this procedure or whether another factor might influence the surgical results. Now, once again, in terms of sleep apnea at that time, it was tracheostomy or this. And CPAP was not yet commercially available or even suggested. So, of course, what we did, we, being the surgical community, everybody got a UPPP because that was pretty much the only thing we had outside of a trach. And even today, I think it's hard to talk patients with sleep apnea into having a trach. So, once again, if you have a hammer, everything looks like a nail. So this is the one article, and in 1996, that if it really flipped the pendulum as to what we were doing, was meta-analysis from 1966 through 1993. And at that time, people were doing nasal surgery, UPPP, glossectomies, you name it, all kinds of things. They looked at all of the papers, and it revealed that it's effective in treating less than 50% of the patients. And so Fujita's original study was about 66%. This said 50%. And they also said that it's most likely to have success if you have mild OSA. And I'm going to say, sometimes papers get published and you can't eradicate them, you can't take them back, you can't do anything. And so to this day, I hear people, pulmonologists, neurologists, that say, you know what, if it's mild OSA, you might be able to have surgery. And it's like, no, not necessarily. So the complaint about all the articles that were published by ENT was that it was small sample size, limited follow-up, and patient selection. So I'm going to say at that point, nobody ever referred to ENT again because they said it's not going to work. You only have a 50-50 shot of that. The idea of mild sleep apnea being surgical amenable was also put to rest, and this was by Dr. Brent Sr., who was at Henry Ford in 2000, and he looked at patients with mild sleep apnea. He got the sleep study before and after, and he showed actually that's not true either. So the point is that the severity of the disease doesn't impact the procedure or the success of the procedure. So now we have like a head-to-head going on between our pulmonology friends, our sleep medicine friends, and ENT. So Barb Phillips was the president of the American Academy of Sleep Medicine. This was published in 2005. She called out otolaryngologists have failed to demonstrate clear-cut benefit of treating sleep apnea with upper airway surgery. Her reasons, outcome variables. Patients felt better. They weren't sleepy anymore. It was quality of life, but the numbers didn't change enough to fit the criteria for surgical cure. If they do a PSG, it's not well. UPPP has been evaluated extensively. However, it's ineffective. Long-term follow-up is rare and incomplete, mostly because if patients felt better, they didn't come back, and you didn't see them. And so it was like, okay, we can't follow them. If CPAP doesn't work or isn't tolerated, other treatments are at least as good as upper airway surgery, although she didn't mention it. So this was counterpoint. So Nelson Powell at Stanford, which was, I'm going to say, kind of the epicenter of sleep surgery, sleep medicine, said upper airway surgery does have a major role in the treatment of obstructive sleep apnea, the tail end of the dog. And it says a surgeon's role can be major. If somebody doesn't use CPAP, it's not effective. What can you do about it? And the idea that ENT was being left out completely, we're tired of being the tail end of the dog. And so I really didn't understand what tail end of the dog meant. And so I had to look it up, and what it means is a small or unimportant part of something. So once again, our canine friends continue to come back to talk to us. 2002, a study came out, and it talked about a clinical staging for sleep-disordered breathing. And this was from Michael Friedman in Chicago. And it was a retrospective study. It was 134 patients. And he discussed if the AHI was less than 20 and it decreased by 50%, it was considered success. And so we came up with the classification. And, for cancer, we do this all the time, right? We stage cancer. Severe, how extensive it is. And so the stage 1 Friedman palate position, 1 and 2. We're familiar with Mallampati. Mallampati is, you've seen it in the pre-op area. The anesthesiologist asks the patient to open their mouth, stick out their tongue. That's the Mallampati. The Friedman is you keep the tongue in the mouth. So favorable, stage 1, 1, 2, big tonsils. Stage 2, it could be an unfavorable palate, but big tonsils. Stage 3, unfavorable palate position and little or no tonsil tissue. He believed if you had a BMI of 40, you shouldn't operate them at all. Just refer them for bariatric surgery, do whatever you're going to do, but don't operate on them. There's no good will come of that. So what he found was that if you're favorable Friedman position and big tonsils, you have an 80% success rate. And then it goes down to 8% if you have an unfavorable palate position and no tonsils. So that's pretty significant. And in my head, I hear Dr. Fujita saying, is there something else that could impact this? But I want you to remember that 80% successful. 80%. So then we said, well, if Mallampati or Friedman is the big tongue base, then maybe we should start operating on the base of the tongue. And so this is from Dr. Chabot, who is from France, this was published in 1999, that talked about tongue base reduction, epiglottal verticalization, mouth floor horizontalization, hyoid bone repositioning, UPPP, septoplasty, turbinate reduction. Wow. I mean, a lot. And once again, I'm going to say, yes, it's a small sample size, 10 patients. And a picture of it was done externally to get into the base of the tongue to remove tissue. Tracheostomy was performed, ICU, NG feeding for 8 days, 5 cases of submental abscesses, 50% abscess. This is like not good, amazing. But once again, 80% success. So we keep going to that. And then it was the age of tours. And many of you may remember going to meetings, conferences, and everybody was talking about robotic surgery. And the reason being is, you could get to the base of the tongue, you could do this kind of surgery, and Dr. O'Malley and Dr. Weinstein were, I'm going to say, leaders in terms of publishing about this, minimally invasive to tongue neoplasms. part of the issue with it is that the Da Vinci, which is shown here, which is the robot, it was only approved for neoplasms for use, for tumors. And sleep apnea really isn't a neoplasm. I mean, having a large tongue doesn't qualify. So although we, ENT, used it a lot, the actual organization or Da Vinci did not support it. So then if we do, a meta-analysis, 8 studies, looking at a larger number of patients, and looking at the results, at success, it was 75%. That was it. So taking out part of the tongue, decreasing the size, and I remember people measuring how much tissue was removed to see if that impacted it as far as success. So then what's the next step? 2016, upper airway stimulation for obstructive sleep apnea. 126 participants, moderate to severe obstructive sleep apnea. The average BMI was 28, 83% male, not surprising. It was an uncontrolled cohort study, which I think we need to remember, or I'm going to show you some of how those patients were chosen. And the limitations of the study are of selection bias of only including responders to upper airway surgery therapy. And the design filtered out patients who had not had a response to therapy. So when you read about the original studies, these were only the people that it worked on, which is, I think, amazing that that was the study design. So, started out with 126. It ended up after that, cutting it down to the 23 that had it turned on and then turned off, and it showed success. And I know this is really hard to see up there, but it actually started out with like 929 individuals that applied for it, and then you have to realize that they kept taking it down till they got those responders. The BMI for the study group was less than 32, but the mean was 28. People that were excluded were circumferential collapse on DICE. Intolerance or inadequate adherence to CPAP brought you in. I think it was 2 years ago, the FDA now approved that you can go up to a BMI of 40 for the hypoglossal nerve stimulator, which is obviously a really long stretch from this group that was 28. Exclusion criteria was extensive. Neuromuscular diseases, it would be something like Parkinson's, COPD, heart failure, if they had insomnia, if they had any other things going on, or if they had large tonsils. So if you actually took that 929 and then you got down to the 46 that succeeded, that actually goes down to 4.9% success of all comers. And so notwithstanding you see commercials on TV that talk about, are you tired of CPAP? Here, try this. You have to recognize the limitation. We are trendy, Before that time, there were all these articles about the TORS and the base of the tongue, and then here you see where in 2014, the FDA approved the hypoglossal nerve stimulator, and that gold line are the articles that have been published about hypoglossal nerve stimulator, and you can see what happens with our TORS studies. All of a sudden, those decrease markedly. So if we look at outcomes for UPPP, so should we throw it away? Does it have any role at all now in the time of a hypoglossal nerve stimulator? And this was a study that looked, again, at a meta-analysis, predictors of success after UPPP, and if they use that Friedman stage 1 success, they find that, yeah, it works well. There is a strong predictor of success. We're, again, probably in that 80% realm of looking at patients and seeing if anatomically they fit. So the thing that's interesting and makes me wonder is that if we look at tonsillectomy alone, if you have a patient with 3+, 4+ tonsils, if you just do that and don't use UPPP, what kind of success rate do you get? And it's interesting because for years we've said, children, there are studies, if they have big tonsils, take them out and it'll cure things. But we really didn't have the same kind of studies that were done in adults. And so since that time, studies have been done that look at it. And if you have large tonsils, 3, 4+, sleep apnea, and you do surgery, you'll see an improvement. And so in this study, It looked at 85% success rate. AHI improved, oxygen desaturation improved, and I'm going to say, I sometimes wonder, do we need to do a tonsillectomy and a UPPP, or will tonsillectomy all by itself take care of the problem? So the question is, we still have that 20% that don't get better, right? No matter what. I mean, the best surgery, they still don't get better. And so I think this is a great article, and it talks about anatomic and non-anatomic problems, issues that can cause sleep apnea. So P-crit is the pressure at which the upper airway collapses, the P-crit. And so anatomic, we know large tonsils, redundant tissue, that kind of thing. The non-anatomic issues are genioglottal muscle responsiveness, arousal threshold, and respiratory control, or something that is called loop gain. And when they did a study of patients with sleep apnea, over a third of them had minimal genioglottal responsiveness. And if you go back to your physiology studies with muscle tissue, you know, when you stress or stretch a muscle fiber, it contracts, right? So with negative pressure, and you inhale, the muscles contract and open the airway. So a third of our patients have difficulty with that. Some patients have a low arousal threshold that says even with a minimal negative pressure, they wake up before the airway opens. And so that feeling of gasping, of not being able to breathe. And then the high loop gain is patients that hyperventilate and then have a pause. And we think of it as central apnea, but obstructive is included in that, and then start breathing again. So sleep apnea is a heterogeneous disorder, and the P-crit is important. So we have to, when we look at our sleep apnea patients, we need to think about that. Okay, so this is an interesting study, and it looks at the collapsibility of the upper airway and AHI. And so the open circles are patients with sleep apnea, and the closed circles are those, I'm going to say, the controls or normal patients. And so you can see on the left side of the graph, at negative pressure, normal patients, their airway still opens up. They're still able to breathe. They don't collapse. Now you look at these AHI, the open circles, and you can see patients at positive pressure, like 5 centimeters, their airway is collapsed. I used to call it a stupid airway, and I thought that was insensitive, so now I call it an incompetent airway. Much like we have incompetent larynxes, we have incompetent airways. So even with positive pressure, 5 centimeters of mercury, they have an AHI of 80 or 100. So it's an incompetent upper airway. It doesn't respond the way it's supposed to. So once again, we can look at these patients, obstructive sleep apnea patients, negative pressure, their AHI is 19, positive pressure, it goes up to 76. It's an incompetent upper airway. It doesn't respond. And so there's this classification, PALM 1, PALM 2, 2B, PALM 3, but the 2A is the sweet spot. Those are the patients that have a moderately collapsible upper airway, and they don't have any of these non-anatomic traits. And so these are the ones that you do a UPPP, they'll do better. They can even roll on their side. They won't collapse. Weight loss will make a difference. Mandibular advancement can make a difference. If there are those patients that have that high P-crit, that even at positive pressure, it collapses, they need CPAP, they need maybe mandibular advancement, something that's going to be bigger than any of these other things we talked about. So it's interesting to think about those 20% of patients that we can't fix surgically, and it's because something else is going on with them. Okay, efficacy is what happens in the lab under ideal circumstances. If you've ever had a sleep study, they put the mask on you, they say lay on your back, lay on your back, lay on your back. You know, keep the mask on. 100% works. Although I've had patients that have gotten up and walked out of the lab, they say, I can't do this. Effectiveness is what happens in daily life. Are you going to do it 100% of the time? I love this study. This is from Bevan Yu and Ed Weaver, and it's with the VA. And they looked at patients, veterans, that had sleep apnea, and they looked at survival. Because in any study, you want to know the endpoint. Is it survival? Is it quality of life? Is it an AHI? What do you care about? So they looked at individuals who received CPAP or had surgery, and it was over this period of time, and they could adjust it for age, gender, race, year treatment was initiated, and comorbidity. They did not have the severity of the sleep apnea, and they did not know if people used CPAP or didn't use CPAP. So that wasn't available. So given that, if we say people don't use CPAP, it's uncomfortable, it's the veteran population, and they're not going to be compliant, what do we see? And what it showed was in this group of patients, and if we say that UPPP only works 50% of the time, you have two modalities of questionable efficacy being compared. And what it showed that for any 1 year point of time, the likelihood of someone on CPAP was more likely to have passed away than the UPPP patients. So the UPPP patients survived for some reason. And we can go back to Barb Phillips, who says it doesn't work, waste of time, don't bother. Once again, it missed a lot of data. Now, in some countries, there is no CPAP. It just doesn't exist. If you're in Brazil, it doesn't work, or it's not available. South Korea, not available. So you either live with your sleep apnea or you have surgery. So nationalized health, you're able to get a lot of information. And so this was a study, I think, once again, a great study that people should look at. And it's from South Korea, and they looked at patients who had UPPP, sleep apnea, and the control group who had sleep apnea but did not have surgery. And once again, CPAP is not available. And they looked at new diagnosis of myocardial infarction, congestive heart failure, atrial fibrillation. And it showed that in the control group, sleep apnea increases the risk of CHF atrial fibrillation. And if I go back to SHEER, where it says small sample size, limited follow-up, and patient selection, they started out with over 200,000 patients. They excluded patients that were less than 20. They excluded patients that had previous cardiovascular disease, and they ended up with 192,000 patients with sleep apnea. 22,000 patients had a UPPP. And so I'm amazed at the data and the other things that were looked at. They looked at income, they looked at urban residency, diabetes, hypertension, dyslipidemia. I was impressed. And here, when you look at this now, and you see what's going on with all of this, across the top, myocardial infarction, control, sleep apnea. So if you have sleep apnea, you're more likely to have the myocardial infarction, the congestive heart failure, atrial fibrillation, more likely. The bottom one, you see that dotted line where the UPPP. So UPPP went close to the control for myocardial infarction, and then once again, this follow-up was for 8 years. I mean, phenomenal follow-up. UPPP, and I cannot understand the congestive heart failure, actually seemed to be therapeutic, and you did better than the controls. And then atrial fibrillation, exactly like the control. So UPPP does improve these metrics. So now we go to the argument about how about CPAP? What does CPAP do for prevention of cardiovascular events and obstructive sleep apnea? And this was done in Australia. Patients were given the device, so it didn't matter. It wasn't about insurance. It wasn't about whether you could afford it or not. And they either put them in CPAP or usual care alone. And they were seen, but usual care alone means sleep hygiene, go to bed at the right time, get enough sleep, don't drink alcohol very much, and come back for follow-up. And the primary composite endpoint was death from a cardiovascular cause, hospitalization, heart failure, TIA. Secondary endpoints were those things that Barb Phillips said was inconsequential, but basically quality of life, snoring, daytime sleepiness, that kind of thing. And what it showed was in the CPAP group, they didn't do any better. They were exactly the same as usual care. They didn't live longer, they didn't have better cardiac outcomes, nothing. And so our colleagues in pulmonary medicine were very sad. They said, we've been talking about CPAP for years, and oh my gosh, look, it doesn't make a difference. But then they said, oh, I know why. It's only because they used it 3.3 hours per night. And if they really used it all night, every night, it would be better, which I don't disagree with. But the point is, in real life, people go out and they don't use it all night, every night. So that's what happens. It did reduce snoring, daytime sleepiness, all those things that we considered inconsequential. So this is a study, and this isn't ENT journals, but this is the Journal of Clinical Sleep Medicine that looked at long-term effects on mental health, outcomes, CPAP for obstructive sleep apnea, systematic review. They looked at randomized controlled trials, non-randomized, and the result was current studies are underpowered with relatively short duration follow-up and methodological limitations. So everything that we were told about CPAP being the answer to everything in the world, I'm going to have to say we have to go back and think about it. In JAMA, and this is another great article. I think this is a great article, 2020. I think you should definitely look at it. And it once again, it talks, and these are by sleep physicians, sleep doctors, that it's a very common problem. The most common presenting symptom is that excessive sleepiness, but not everybody with sleep apnea has that. And the two reasons or causes that we should treat patients with sleep apnea are resistant hypertension, you're on 3 or more drugs and it's not being controlled, and if you have hypersomnolence. And they basically said if you have asymptomatic sleep apnea, weight loss, exercise. And CPAP for patients who are hypersomnolent or have resistant hypertension. So the idea that if you have sleep apnea and you're going to die of a heart attack or of a stroke isn't really supported. So the emperor has no clothes. And you know, once again, I'm thinking this is something that we need to be aware of, that we're using the AHI. And insurance companies are using it, we're using it, we call severe, moderate, mild, and the point is, none of the metrics that we want to correlate with AHI. You know, morbidity, mortality, resistant hypertension, none of those correlate with AHI. So when do we get rid of it? When do we start talking about something else in terms of that? And the fact that all of these studies with CPAP treating sleep apnea, if it's not showing any improvement, then maybe we shouldn't be looking at the AHI and we should be looking at something else. Otherwise, we need to just say, why are we doing this and why do we bother? So it started making me think about diabetes. Okay, so we talk about the first sleep apnea patient. They said it was Fat Joe in the Pickwick Papers. You know, diabetes was described in the 1500s. Patients are overweight, much like sleep apnea, decreasing dramatically in the past 3 to 4 decades, absolutely. We started using insulin deficiency versus insulin resistance. We have type 1, we have type 2. So we've learned a lot about it. But the first article about glycosylated hemoglobin was actually in 1984. And I'm going to say that some of us in the audience may have learned about fasting blood glucose, and that's how we took care of our patients until the glycosylated hemoglobin, which is now the standard of care. And so this was published, 1984, and it indicated that the glycosylated hemoglobin assay provides information about the degree of long-term glucose control that is not otherwise obtainable in the usual clinical setting, and it was considered to just be a research tool. So before that time, I'm going to say we asked our patients, how many times do you go to the bathroom, how much water do you drink, and you'd get a fasting blood glucose. And that's how we treated our patients. But I'm going to say today, that's not what we do. We look at the hemoglobin A1C, we look at many other parameters, the creatinine, lipid, retinal eye exams, and I'm going to say for sleep apnea, it's probably very much the same. We need to start looking at larger data that we collect to see what really correlates with either the hypersomnolence, hypertension, and the things that matter to us. And this was recently published that 2024, should we look at ventilatory burdens? Should we look at those people that start doing the little puffs at night when they breathe? Should we look at whether they're symptomatic, not symptomatic? And should we just treat those patients that are symptomatic and we don't look at the AHI? The other question is hypoxic burden. How much time do people spend under that 88% threshold when they're sleeping? So for years, I would have patients come to me, and once a year they'd come in and they go, so is there anything new for the treatment of sleep apnea? And they go, when are you going to come up with a pill? And I would laugh. I go, we're never going to come up with a pill. That's silly. Well, guess what? We've come up with a pill. So there are different types, noradrenergic reuptake inhibitors, potassium channel blockers, hypnotics, GLP-1 agonists. So this was a study that was done at our institution. You know, for years it was like you have to use CPAP. Now it's like, oh, are you tired of CPAP? Why don't you come in and do this study? So noradrenergic reuptake inhibitor, atomoxetine, and there are different kinds. But if you think of the medications that an individual uses for ADHD, and it basically just increases the tonicity of the muscle fibers, so they're more likely to react. The problem with just doing that by itself, however, is that you're more likely to wake up and then not get a good night's sleep because you're waking yourself up. And then so they added an antimuscarinic so that it decreases the arousal threshold. So they have these now, they're going through the stages of approval in terms of increasing the tonicity of the muscle fiber. So that 20% that we said don't respond to surgery, we may be doing surgery and then adding a medication to it because it improves the pharyngeal collapsibility that we talked about. So there's several different medications now that are the reboxetine, also having the antimuscarinic that shows improvement in that subclass of patients. And then in Australia last year, they came with a potassium channel antagonist, which is a nasal spray. So you can spray it in your nose, and then that'll increase the muscle tone of your pharynx when you go to sleep. And so you have that little bit of negative pressure, it responds appropriately, and you're able to breathe. Last year as well, tirzepatide has come out for obstructive sleep apnea. It's the first study, because Ozempic and Wegovy, people were using it. You lost weight, and your sleep apnea got better, which we're aware of. But it never specifically targeted sleep apnea. This study was the first study that looks at sleep apnea in terms of improvement. Primary endpoint, unfortunately, was AHI. After that, however, was hypoxic burden, functional outcomes, and cardiometabolic markers. And so the group on the left were patients that were CPAP naive, and the one on the right where they had used CPAP, had stopped it, and then went on the study. And it showed marked improvement in AHI, body weight, and the other markers that they looked at. So here was the study that was approved. It was published almost a year ago, randomized control study for tirzepatide and obesity. And here you can see the placebo group didn't change a whole lot in terms of what their AHI was and their weight. Tirzepatide did quite well. Dr. Lucente talked about the definition of research, and so hopefully today I gave you some information about things that you can look at, think about differently. You know, I think about with big data and that kind of thing. If we looked at all the patients that are on some type of medication for ADHD and the incidence of sleep apnea in that group versus group that isn't as the control, same age, maybe we're treating some patients and we don't even know it. So we started with dogs, we talked about dogs, now we're back to dogs. And this may be that typical patient who may be a member of your family. And I don't know if anybody here has a pug or a bulldog or anything like that, but you know, snorting, snoring, noisy breathing, exercise intolerance, restlessness at night, apneas when sleeping, all that kind of thing. And it turns out that Cambridge University is the epicenter for this syndrome, and they call it brachycephalic obstructive airway syndrome, BOAS, which is basically for those animals that have the flattened facial features, short face, and you can see that the uvula goes down to the epiglottis, the tongue is very large, collapsing the airway. And so I actually like the obstructive airway syndrome more than I like what we call it, OSA, because many of these, our patients, you can hear them when they're awake breathing, they're loud. And so, yes, they're doing surgery and they're doing our UPPP procedure on these dogs. Now, I'm not suggesting that anybody go home and do this, but yes. And so hopefully from this talk today, you've learned something that's been helpful, something you didn't know before, something that's interesting. And sleep medicine board certification, there are 7 specialties that can become board certified. ENT is one of them, pulmonary, pediatrics, anesthesia, neurology, psychiatry. And these are programs, it's a 1-year fellowship. It's the easiest fellowship you'll ever have to do, and because it just is. And these are centers that are collaborative, that have ENT embedded in the program, so you can do surgery, you can do your sleep medicine, read your sleep studies, do all the things you need to do. So I certainly encourage people to participate, to look in this, especially residents, because it's one of the areas that has the greatest growth, I'm going to say, and need for in academics. International Surgical Sleep Society is going to be a shoulder meeting in front of our annual meeting, so certainly encourage people to attend that as well. So thank you.
Thank you so much, Dr. Yaremchuk. Any questions for Dr. Yaremchuk?
Is that we only look at it, and as you mentioned, rightly, if I should say, it's a complex problem. It's not one anatomy. It's not one basket. That there are many aspects and different pathologies that cause this problem. And what I look at the research, what I see is that we're trying to find one solution for a patient. And I think the answer, and that's what I see in my practice, and is in combination of treatments. For example, patients who are not doing well, cannot tolerate CPAP for a long time, and are a good candidate for the hypoglossal nerve stimulation implant, I can implant them. But if it's not giving them the absolute benefit, I can add another treatment, whether it's medical or CPAP, and the combination of treatments will get the solution that we need.
I agree with you. I think that we've always thought of one and done. We're used to doing one procedure and then we're done. And that's just not the way. I know. All right.
Probably more oxygen to saturation, and Title II is more important. But then there's this whole issue in pediatrics that the sleep study's never been shown to be predictive of anything. It doesn't predict neurocognitive issues and how you do in school and cardiovascular. It's really a non-predictive study, but we focus
I know. So we're
on it
treating a number
so
and not a
much.
patient. And that's my biggest thing. And so I'm trying to develop a red cap type survey. You know, if we go back to 1984, and I go, all the sleep studies that were done at Henry Ford that at that time were paper, but we start to look at them, including kids, and then look at long-term outcomes. You know, what does it matter? And is it the oxygen? So I agree. We know, what we know is less than what we should know.
Ann Plum. So I completely agree with Dr. Goldstein and you about the AHI. You will see kids who the parents describe they're breathing at night and you think the kid was dying. And you get the AHI back and it's 0. The oxygenator is in the 90s. You'll also see the flip where parents really aren't concerned, but the kid has huge tonsils, so you get a sleep study and has severe sleep apnea. And I think both Naira and myself have, for the ones who have incredibly severe symptoms, but sleep study by any metrics is not impressive, we've started doing more of the partial intercapsular tonsillectomies, and it's worked great. So it might be something to consider with adults too.
Thank you so much for an amazing talk and a trek through history, which is very important, but I think this is where the sleep centers with the multidisciplinary combined approaches treating the whole patient comes in. Yes, research is important and markers are important and knowing exactly what we're doing is important, but approach to a patient whose quality of life and their medical history and comorbidities, they all have to go into a bucket that we need to address, right? Surgery seems to be a permanent solution. It is, we cut and it doesn't grow back, and they don't have a choice to put their CPAP, in the closet. But, we do need to also address their weight problem, their sleep hygiene problem, their mental health issues, everything that comes with that, their diabetes and hypertension, which improves once you address the other issues as well. I'm a believer of surgery, but I'm also very, very careful about patient selection. So CPAP may be a good, their compliance and their reading of, their CPAP cards, downloading their compliance is maybe a very good, indicator for patient selection for sleep apnea and how motivated they are to address their health issues.
Yeah, I'm not down on CPAP if they use it 100% and they're happy. There's also the question, though, we're probably treating a lot of patients we don't need to treat. And if we're talking about healthcare costs and all those kinds of things, if it really isn't deriving any benefit and they're just wearing a mask, and that's the whole idea of research as far as this opportunity to really decide patient-centered outcomes, strategic, looking at patients, does it make a difference, does it not? And whether it's surgery, CPAP, medication, any of those things.
Just wondering if Dr. Lucente has any questions or comments. We can't see him right now, but I just want to make sure he has an opportunity if he had any comments or questions. Okay. I actually have a question, Dr. Yaremchuk. So talking about history and kind of looking at sleep apnea from a public health standpoint. So interestingly, in New York City, I think this was beginning in about 2016 or 2017, the MTA, our public transportation system, after several very unfortunate and high-profile train accidents, derailments where people were going at high rates of speed, there were derailments, and in many of those cases of accidents, some that resulted in like rider deaths, they looked back during the investigation, found that several of those train operators had untreated sleep apnea. They were tired, and they were, their decision-making was off, and all the things that we know that impact you cognitively. So the MTA actually began the first ever screening program for OSA amongst anyone that was either a bus driver, a train conductor, anything like that. So they started screening you based on certain, risk factors. Increased BMI, wide neck, all these things. And so our practice was one of the otolaryngology groups that was getting the referrals of these patients that went on to get sleep studies, and we would have to talk to them about needing OSA, and the MTA made them stop doing their jobs until their OSA was treated. So I guess I'm wondering, that program I think kind of went by the wayside post-COVID. We don't see those patients as much anymore. I don't know if that's been a priority given the other issues that the MTA is dealing with right now. But I'm wondering what you think about something like that, like people that have very, jobs that have an impact on public safety, what do you think about the concept of doing something like that?
The FAA has this for pilots. If a pilot has they have to have an annual physical exam. If they have a BMI greater than 40, they have to have sleep evaluation for sleep apnea. Commercial license, the states don't mandate it, but the insurance companies that insure them mandate it, because if there's an accident, they're going to end up paying for it. So the insurance companies have mandated it, commercial license. And so I see the truck drivers, I see all that kind of thing. And you make the diagnosis, you give them CPAP, but you can't make them use it. And they may be compliant for a month, because you can see that. But once they've done the compliance, it doesn't mean the next 11 months they're going to be compliant. And so I kind of think of the, if someone has had a history of a DUI, they have to blow into something before their car will start, kind of thing. And I'm wondering if for sleep apnea, we should have that same kind of thing, unless they show that they've used their CPAP or, are on medication that they can't drive their vehicle. So I think it's for that group that's hypersomnolent, and it may only be 20% of patients or 30% that have sleep apnea that are actually hypersomnolent, but for that group, I mean, I had one lady, she was, I still remember this, because she was legally blind and she had sleep apnea, and she was talking to me about her sister who was an ophthalmologist, and I said, well, so how did you get here today? Because she wasn't with anyone in the office, and she goes, I drove. And I said, oh my God. I go, you're legally blind and you have sleep apnea and you're falling asleep in the chair, but you drove. She goes, I go really slow. I said, okay. But I wanted to know where she lived and what time she was leaving, because I didn't want to be on the road at the exact same time she was. That's all I cared about.
Thank you so much.